Hey, hello everyone and welcome. My name is Maura Canvan and I am with the Suburban Hospital Community Health and Wellness Department. You will be seeing me with the Rockville Senior Center webinars from now on. So today we are here to discuss common foot problems that affect mobility and comfort, and with our podiatrist, Dr. David Engorn. So he will address bunions, hammer toes, fungus, and corns, as well as foot hygiene and proper shoes. We will have time for questions at the end, but please feel free to ask your questions as they arise in the Q&A box, and we will make sure to address them at the end. In addition, this webinar will be recorded, so you will have access to the recording after. It will be sent out in the following week, which is great. And then we would also greatly appreciate your feedback. So you will receive a link to an evaluation at the following this webinar in your email. And we would love your honest feedback so that we can continue to improve our programs. So thank you everyone for joining, and I'll pass it off to Dr. Engorn. Thank you.
All right, thanks, Maura. Thanks for the introduction. Hello, everybody. I am David Engorn. I'm a podiatrist in the community. I've been in town for now about 7 years after my training, and I've done these webinars a handful of times through Suburban. I've really enjoyed doing them, and it seems that the foot and ankle podiatry ones get good turnouts, and it looks like this is another one. So thanks for joining, and I'll try and get through as much information as I can. You'll see a bunch of on this front, this first slide, you'll see a few different logos. The center logo there on the bottom, the Centers for Advanced Orthopedics, that's the practice that I work for now. So it's the practice is the division I work in is the Orthopedic Center, which is right across the street from Shady Grove Hospital, one of our offices. That's our flagship office. And I can give you guys that information at the end of the slide, so you can know where to find me if you need, or if you have any further questions for me. I am a semi-local guy. I'm from Baltimore, and went to University of Maryland for undergrad, and then moved down to Miami. You can see on the Barry University is where I did my medical school, and came back up here in 2013 and did my training at Georgetown, and then I practiced for a few years with another podiatrist here, and then I actually moved out to Las Vegas last summer, and somehow convinced my wife to pack up and take the 2 kids and move out there to do an extra year of training, which was a spectacular year in the desert. And I was fortunate to work with the professional athletes out there, the Raiders and the NFL team and the Golden Knights, which was a really neat experience. So my experience with foot and ankle is quite vast. My training at MedStar was it's a level 1 trauma center. I saw a lot of trauma and diabetic foot infections, and so it was a quite academic program. So I got really good training in that part of foot and ankle, and then I went into practice. I was working for a podiatry practice, and then advanced my training in more of an orthopedic type area with these athletes. So anything foot and ankle related, I've seen, I've learned about, and I treat. So hopefully this isn't you guys at the end of this talk. This is my now 4-year-old Caleb. When we moved to Las Vegas, there was that, the time difference of 3 hours, and it took him about 2 weeks to adjust. And so this was a picture that one of his new teachers took of him, and sent it to us, and told us he was so excited about what he was learning that day. So hopefully this isn't you guys at the end of this. So if you saw on my slide, the first slide, I had identified myself as a podiatric surgeon. It's a term that we use in our specialty And my profession, the DPM profession, Doctor of Podiatric Medicine, has many names. So podiatric surgeon is one of them. Podiatrist is another one. Foot and ankle specialist is another. But as I had mentioned, we are trained to treat all of the foot and ankle, and all types of patients, athletes, kids, elderly, the whole thing, trauma, foot care. And so it's a pretty wide range of pathology that I see, and that I'm trained to recognize and treat. So just to kind of start, I'm going to go over some things about the aging foot. I think it's important to know what's going on with your foot as you age. Some of this stuff you might know or and might be obvious to you, but I thought it was important to talk about as normal, what's normal in the aging foot. So the first thing you can, what you might notice is that your skin thins, right? Your fat vanishes. You develop atrophy in your skin. And the reason for this is that as you get older, your collagen production goes down. So you have less collagen, and your skin looks thin, as you can tell in the picture that's on this slide. So that's one thing that you might expect with your feet and your body as you get older. The next is arthritis. You can develop arthritis. The foot is most people, when they think of arthritis, they think of their knee or their hips or their back. But the foot is quite a involved part of the body. There are many bones, many joints, and so you can develop arthritis in any of them. But most commonly, the big toe joint, which is where on the picture the person's thumb is pointing to, and so that's a common part of the foot that I see arthritis in, as well as the midfoot and the ankle. Your toes can curl, right? So we know these as hammer toes, and that can develop over time. And I'll go into this a little bit more later, but you might see your toes bend and you develop corns on the top of your toes, or calluses on the bottom of your feet that are ultimately due to a tendon imbalance in the extensor tendon, which is the tendon on the top that pulls the toe up, and the flexor tendon, which pulls the toe down. Over time, your circulation slows, and this can be because just of your vessels weakening or some other disease process like diabetes, which I do see quite a bit of. Some other things that you might see is your tendons. So and this is what can lead to hammer toes. Your tendons can tighten. So you'll see those toes are bent because the tendons on the top are tight. The extensor tendons are tight. And why do they tighten? It's because the water content in the tendons decrease over time, and that causes the tendons to become stiff. And so that leads to hammer toes. On the other hand, and so tendons, just to be thorough, tendons connect your muscle to the bone. So that's what a tendon is. You use your Achilles tendon, for example. It connects your calf muscle to the heel bone, muscle to bone. Ligaments, which is point number 2 here, ligaments are a similar structure. It's a soft tissue structure that connects bone to bone, not muscle to bone, but bone to bone. So while tendons tighten over as you age, ligaments actually lengthen and weaken. So they do the opposite. And what you can develop with weakening of ligaments is deformity in your foot. You can develop a flat foot, or you can sprain your ankle easily. And more, even beyond that, when you have lengthening of these ligaments, there are what's called proprioceptors in the ligaments on the bone that signal to your brain that you are that provide you with balance. So if you're about to sprain your ankle, your brain recognizes that you're about to sprain your ankle, and the way it recognizes it is that the ligament stretches, signals the proprioceptor, signals your brain, and you catch yourself. As you get older, you don't have that ability, and so your balance becomes a little bit compromised. You'll see the third point on this slide is that as you get older, your skin and nail color changes. Your nails grow slower, and this happens because your hormonal production goes down. I do see a lot of patients with thickened and discolored nails, and I'll go over that a little bit more later, which may or may not be a fungus. And if it's not, one of the ways to treat that is by taking a supplement, biotin or type 1 collagen. So that's the aging foot, and just what I was assigned to do is go through the most common foot and ankle pathology that I see. I'll go through just simply what it is, how you treat it, how you recognize it, on a very surface level. So heel pain. This is probably the second most common thing that I see in my practice, both in my practice prior to my fellowship and now. When people come in with heel pain, it's either in the bottom of the heel or the back of the heel. So that's the first question I always ask: is it the bottom of your heel or the back of the heel? If it's in the bottom of the heel, to me, if there's no trauma and there's no open wound, if you have pain when you first get out of bed in the morning, that is in the bottom of the heel. That's plantar fasciitis until proven otherwise. Typically it's a sharp pain. It hurts when you first stand up, and sometimes it can improve throughout the day. If you have pain in the back of your heel, that's Achilles tendonitis, which can be similar, where it hurts when you first get out of bed in the morning, but or there's stiffness, but it's in the back. So often I'll hear patients say that when they're going up or down the stairs, they need to use the railing not because of balance, but because they have pain in the back of their heel. And that often, to me, signals that there's inflammation in the Achilles tendonitis. Some causes of both are just overuse. So it's the winter, you're not exercising much, and then the spring rolls around and you go for walks with your dog or your spouse, and you start to develop this pain in your heel. Your body wasn't used to it. So overuse is a cause of it. Weight change. If I see people that if they've increased weight in the last several months, they can develop plantar fasciitis or Achilles tendonitis. Shoe wear. People who wear, I see a lot of guys that are wearing loafers that are flimsy. They can develop Achilles tendonitis, plantar fasciitis. And so these are all things that can lead to it. But the number one factor that we believe leads to either of these problems is a tight calf muscle. So if you look at the image, you can see where the Achilles tendon is on the back. I'm not sure if you can see my mouse, but here's the Achilles tendon. Just above the Achilles tendon is your calf muscle. So what we think is happening is, over time, your calf muscle is tightening, which pulls the heel bone up, And when you first get up in the morning and you take a step, you're pulling the Achilles up and the plantar fascia out. It's stretching. All of it is stretching, and you get these micro tearing either in the fascia or the Achilles. And that micro tearing is a signal to your body to bring on an inflammatory cascade, which hurts. So with these, often the first line of treatment is an anti-inflammatory, ice, rest, eliminate the fat, what may be causing it, whether it's flimsy shoes. So I often tell people to wear a pair of Vionic sandals that are arch supports, or Fit Flops, another pair of a good supportive sandal around the house, and not walk barefoot, because that can lead to it. The second thing the pathology that I see often is arthritis. As I mentioned, before, I see it typically as people get older, or it's post-traumatic. So you have an ankle fracture, and down the line, you start to develop ankle pain. You can, based on the fracture that you have, you can develop arthritis in your ankle, or you stub your toe badly, you break your first metatarsal where that arrow is pointed to. That can ultimately lead to arthritis. But I would say most of the patients that I see, the majority are from just normal wear and tear with all the miles that you put on your feet. So the big toe, if that's where the picture at the top on the right, the big toe joint, that's what it's pointing to. You can see that little bump on the top. That's a telltale sign of some arthritis. It's either a trauma related or it's mechanical. So what I evaluate for when I'm looking to see why you have arthritis of the big toe joint is I check the foot position. Are you an overpronator? Do you have a higher arched foot? Do you have a tight calf muscle? There's many things that that are deformities in the foot that can result in arthritis. And so the key to treating these is addressing what that underlying cause is: flat foot, high arch, is it trauma, things like that. What I'm always recommending to people is a stiff-soled shoe when they have big toe joint arthritis. The pain that people experience is the limited motion that they have, right? So arthritis is what it looks like, is bone spurs, extra bone that's forming to protect the body. So your motion is not completely limited. It's not absent. There's a tiny little bit of it, and that little bit of motion hurts. So if you wear a stiff-soled shoe, you're eliminating the motion. So you're eliminating any inflammation that may come from that limited motion, and then the pain, can be treated that way. An anti-inflammatory for this any of these types of arthritis, I find can help. Either by mouth or an injection. I usually give an injection as a first-line treatment, knowing that there is usually structural damage, there's cartilage loss, there are bone spurs, things of that nature that you can't fix with an injection, but it does get rid of that acute inflammation that's in the joint. There's another device called a Morton's extension. You can build this into an orthotic, very similar to what a stiff-soled shoe would do. It's just a solid extension in an orthotic that prevents you from being able to move the big toe joint up and down. Midfoot arthritis treated very similarly with a rigid device, a stiff-soled shoe. It's the onset of it is very similar, or the cause of it, trauma versus mechanical, is similar to the big toe joint. Custom orthotics are really helpful for this, injections, and then ultimately there is surgery, which is it's an option if the conservative treatment fails. And then lastly, I see arthritis in the ankle joint. This is usually post-traumatic. It's from some sort of injury that people had, whether that be 20 years ago or 50, whenever it was, and they've developed arthritis in the ankle joint. You can see the brace at the bottom on the right-hand side. That's called an Arizona brace. They're custom. And what it does is it just controls the ankle, similar to what a stiff orthotic would do. It's rigid. This is a rigid device that prevents you from moving your ankle up and down while you walk, and therefore eliminates any pain that you might have. And then, of course, if that fails, there are surgical options too, such as an ankle fusion or an ankle replacement. Bunions are it's always a fun conversation to have with patients when they come in, because they've usually been provided lots of information from their neighbor or their friend about their bunion experience, or their friend's bunion experience, and it's usually never good. But I'll tell you that bunion, if you do go down the route of bunion surgery, I have found in my practice, it's actually it's the percentage of unhappy patients is much smaller than probably the common person thinks. So a little bit about bunions: they are hereditary. We believe that they come from your maternal grandmother. So if your mom's mom had bunions, then there's a good chance that you might have them too. I don't know if you can see this x-ray, but basically what a bunion is, it's this, you might know, but there's a bump on the side of the big toe joint underneath of this silicone spacer that can rub in shoes. And it's just a big bony prominent area that can be aggravated. It's progressive, so it gets worse. What I look for when I see someone for the first time with bunion pain is I try to figure out, is it bump pain? So does it hurt in shoes, or is it joint pain? Does it hurt inside the joint? And it's sometimes a hard question to answer for patients. So I do an examination, and then it's quite easy to determine if I put the big toe through range of motion, it either hurts or it doesn't. And then when I push on the medial eminence, which is the big, the first metatarsal head, it either hurts or it doesn't. So we have found that longstanding bunions, if they're untreated, they can lead to arthritis of the big toe joint. Some non-surgical options are wearing a wide toe box shoe so that there's no rubbing or less rubbing, a bunion shield like in that picture. You'll see in the bottom right-hand side of the slide, my X is kind of covering the device, but there are companies out there that have made these devices that claim that they can fix your bunion with a strap or some sort of crazy thing. I think that, sure, you could try it. It might make you feel better if you're laying in bed, although I don't think that most people have much pain laying in bed with their bunions if it's not arthritis. So these devices, I think, are probably not, to me, it might be a waste of your time and will not fix the actual deformity. You'll see here at the bottom, I mentioned minimally invasive surgery. I'll go through that a little bit more later, but it's a new technique that I've been doing for the last few years. I honed those skills in my fellowship, much less swelling after the operation, small incisions, walking much quicker after the surgery, and patients are very, very happy. Hammer toes, we talked about the imbalance of the tendons on the top and the bottom. And so these also are hereditary, they're progressive, they get worse. I think it's important to see, if you look here at the second toe, what we always have to look for is if there's a second toe deformity, how much of a contribution is the big toe playing on that second toe deformity? Because if we're going down the pathway of correcting these surgically, if you fix the second toe alone and you leave the bunion, we still we potentially we could have a recurrence down the line of the second hammer toe contracture. In terms of how to treat these non-surgically, there's some straps out there that they're called hammer toe straps that pull the toe straight. If it's a flexible hammer toe contracture, that may work. If it's a rigid hammer toe contracture, most likely that won't work. Wide toe box shoes, New Balance makes a really good wide toe box shoe that I like, that accommodates deformities like this. And then, of course, with the hammer toe, you'll see on the top of your toe, you can develop corns that become painful. I see this on all the toes, not just the fifth toe or the second toe. I see them everywhere. You can have them shaved down. That's part of my practice, what I do. Medicare actually will pay for that procedure. So any podiatrist can do that for you. And the same with calluses on the bottom. So there's a corn versus a callus. Corn is on the top of the toe. Callus is on the bottom of the foot. Calluses are also, you can see them on the sides of the big toe as well. And then, of course, you can fix these surgically. There's many different operations out there to fix the hammer toe contractures. Toenail fungus. So toenail fungus is a problem. And I say that because it can be quite difficult to treat. And you may have heard that you may have read that or heard that from other providers that you might have seen, whether it's your primary care physician or a dermatologist or another podiatrist, because it can be tough to get rid of. My thoughts on fungus are, it's important to know, especially in an aging population, it's important to know, is it fungus? Is it truly fungus? Because nails can look like fungus, but not be fungus. And the way that we know that is take a little sample, send it to the lab, they look under a microscope and tell us. And what you'll see in fungal nails or thickening nails that may be not fungus is discoloration, thickening, they're crumbly, and they detach from the nail bed. It's been documented that about 10% of the general population have toenail fungus. 20% of the population older than 60 years old have fungus, and 50% of the population older in the United States older than 70 years old have toenail fungus. Toenail fungus, the medical term for it is onychomycosis. It's another word that's used for fungus. In what I have found and what I've read in the literature, more so what I've seen in my practice, is that topical medications alone, they're about 20% effective, maybe even less. That's probably an overestimate. But in general, a topical alone, I think, is quite ineffective. But it's safe because it's a topical and it won't cause any damage. You don't have to ingest anything. And there's many out there. There are ones that are simply one medication. There are ones that are multiple medications in one. There are compounds that have urea cream in it that moisturize the nail and allow for better penetration of the antifungal medication. There's many different ones out there, and it's kind of dealer's choice on what you use for it. And there's a couple of different pills out there. I'm sure most people. There's a pill that you take once a day. You typically have to take it for 3 months. One's called Lamisil. It's probably the most commonly prescribed oral antifungal. It's effective. It works 80% of the time. There's risk, some risk, low risk. I'll tell you, in my practice, it was rare that I saw liver enzymes elevated from taking it for 3 months, but it can happen. And that just means your liver is overworking or working harder to metabolize the medication. And in those patients who I saw their liver enzymes elevate on it, they were typically taking other medications that were metabolized by the liver. So there's risk, and it's a known risk, but the medication itself does work. And then lastly, as I mentioned previously in one of my earlier slides, biotin. I tell patients all the time, biotin is a great vitamin to take for your nails and your hairs and your hair. And there are other multivitamins out there that I think are very that have been shown to help with just overall nail health. And sometimes, I think we focus on treating fungus when really we need to be treating the health of the actual nail, and especially if we have a negative biopsy culture result from the nail. Ingrown toenails. I see ingrown toenails often. I see them a lot in my younger patients, kids that are playing soccer, that are wearing tight soccer cleats. They're cutting a lot, and their toes are jamming. They're jamming in the toe box of the shoe. So that's one reason why you get them, is just jamming in the shoe. What you should be doing is cutting your toenail straight across. Don't cut them on angles. I know it's sometimes it's very tempting to cut them on an angle. I do it. I'm guilty of it. I've also had ingrown toenails that I've had colleagues take out of my toes. So I know that it's a real thing, and that you can get them from cutting your nails improperly. Don't cut them too short. That's a problem. My 5-year-old bites his toenails too short. He gets ingrown toenails. It's a problem. Luckily, I haven't had to pin him down and put lidocaine in his toes and take out the ingrown toenails. One of my biggest fears is to have to do that to him. So what we see with ingrown toenails is that typically if it's whatever the trauma may be, whether it's your shoe or it's the way the nail was cut, it's the adjacent skin that swells. That's the redness, and can sometimes become infected, which is called a paronychia. Those, if I see a paronychia, those are treated with usually an antibiotic by mouth, depending on the severity of it. Soaking in warm water and Epsom salt, it's a great thing. And then some sort of topical antibiotic, whether it's Neosporin or a prescription strength, is usually what I prescribe. There is a permanent procedure that can be done. I do this all the time in my practice. where the toe is anesthetized, put a little bit of lidocaine in, and then remove the offending nail. And once you do that, the adjacent skin inflammation goes down, and that nail is no longer sitting in the skin. And this can be a permanent procedure, or it can be a non-permanent procedure. The permanent procedure is where a chemical is used called phenol, which I do in the office, or there's a procedure called a surgical matrixectomy, which is where rather than burning the matrix, we cut the matrix out. So the corner of the nail comes out, and the matrix where it grows from gets either cauterized or excised. You'll see this little funny device at the bottom of the screen. Another one of those, I think, gimmicks that probably, I don't know. I am not sure what's going on there, but it seems like torture to me. I don't know if I put that on my toe or my kid's toe. I don't think it works. So corns and calluses, I touched on this a little bit. I think what's important to know is that that there is often a underlying bony prominence. There's usually something that's under the skin that's leading to this. In the top picture, that toe, most likely it's not a bony prominence, but it's the deformity of the toe. It's the bent toe that's rubbing in the shoe that's causing that corn to form. And they can be shaved down. As I mentioned previously, Medicare pays for that. They can be shaved down, which provides relief, but ultimately they do come back unless you fix the underlying problem, whether it's a bony prominence or a deformity. Sometimes when I see these skin hypertrophic lesions, you have to consider it a wart. Warts have a classic look to them, and in a situation where it's unclear, is this a wart, is this a corn, then I typically biopsy it and send it to the lab to see if it is a verruca. Other types of skin lesions that I see on the bottom of the foot are something called a seborrheic keratosis, or a clogged sweat gland. So the bottom of your foot has lots and lots of sweat glands. Those glands can actually clog. We're not sure why, but they clog, and that clogged part of the gland gets calloused and hard. And the way to get rid of that is to see somebody and have them shave it down, pare it, get rid of the clogged part, take it out, which is painless, but it provides quite a bit of pain relief. When I see calluses and corns, I always think, what is the cause? What's the deformity? What's the prominence? And there's always an orthotic or a plastizoid insert, something that can accommodate this area to offload it or to fix the deformity. And as you can see on the bottom, to always try to treat the cause. Neuromas. So neuromas I see quite frequently. This is a diagnosis typically made clinically. The presentation is often, people will say there's burning, there's tingling, there's numbness in 2 toes, maybe more. It's uncommon to see 2 neuromas in the foot. You can, but it's more common to see 1. You'll see in this picture, the red 3rd and 4th toes is your classic Morton's neuroma, which you might have heard. That's in the 3rd web space or 3rd inner space between toes 3 and 4. I do see them in the 2nd and 3rd web space, and much less commonly in the 1st and 4th. So sometimes people will present with symptoms of feeling like they're walking on a balled up sock, or there's something in their shoe, and that's a classic sign of a neuroma, specifically in this part of the forefoot. These can be somewhat. You have to do a thorough exam to really to diagnose these, because just next to the neuroma there's something called a plantar plate, which is it's a ligament. It's a soft tissue structure. It sits right next to where the neuroma or the nerves sit, and those plantar plates can get inflamed or torn. And so it's really important to look at, to push around. We have ultrasounds that we can use to help determine, is it plantar plate? Is it neuroma? Sometimes an MRI is useful in helping to diagnose this, but it's another pathology in this location that we rule out or rule in. What causes neuromas? Walking barefoot, unsupported flimsy shoes, just like I was describing, people who wear loafers and who walk barefoot. They often, I see them with this developing neuromas. If you have one, you can soak your foot in warm water and Epsom salt. Don't walk barefoot. This thing on the bottom picture on the right, that purple pad, is called a metatarsal pad. I love these. I recommend them all the time. You may have seen them. You can put it directly on your skin, or you can put it in your shoe if you can figure out where it needs to be. The important part of it is that the pad is sitting just behind the metatarsal heads, right? So if you look at the neuroma here, the metatarsal heads are adjacent to it. You want your pad just behind it, so that it's offloading that area of the inflamed nerve. I've mentioned custom orthotics a handful of times. I do make these. Most podiatrists do. They are a prescription device that control abnormal foot mechanics. So, most often I would say that probably 65% of my patients that I prescribe an orthotic to have some sort of pronated foot type that collapses, flattens. And the other minority would be people who have a higher arch type foot. And the whole idea is to just stabilize the foot, stabilize the bones and the ligaments and the tendons, and this can provide relief. And then, of course, there are modifications that we can add to the device to help for symptomatic relief, such as the metatarsal pad that I was just talking about. There's plastizote that you can put on top that'll make it more accommodative if there's painful bony areas that need to be offloaded. And we think that these orthotic devices actually do help with the progression of the foot deformity. I don't know if that's necessarily, I can't say that is true in all cases, but we think that is the case. But even more than that, it helps with symptoms. And so I prescribe this all the time, orthotics all the time, to kids and to adults and athletes and non. And I find that people are usually often quite happy with them. Diabetic foot ulcers. I could talk for days about this topic, as it's a part of my practice, and as I had mentioned, I did extensive training on it. Just the kind of the very quick points about diabetic foot ulcers. I see them. The reason that people develop a diabetic foot ulcer is it's a triad. So there's three things that happen. One is that in diabetic patients, the poorly controlled blood glucose leads to a loss of sensation. So they have something called neuropathy, and so they can't feel. They have compromised circulation, so their blood flow to the nerves is diminished, so the nerves aren't working as well. And then they have some sort of deformity, whether that's a bunion or that's a high arched foot or that's a flat foot. There's some sort of bony prominence under the ulceration that causes the ulceration. And so these are complicated. They're complicated problems. They usually require a multidisciplinary approach for management with myself, sometimes if it's infected, the infectious disease doctors and vascular surgeons and plastic surgeons. It can be quite involved, but I do see them. And then just a list of some other things that I treat in my practice. You'll see this is an ankle fracture that was fixed. I would say that in my current practice at the orthopedic center in Shady Grove and Germantown, the number one pathology I see is ankle sprains. I see tons and tons of ankle sprains. I see lots of ankle fractures, foot fractures, metatarsal fractures, toe fractures. As I mentioned, I see a lot of diabetic patients who come in for routine diabetic care once a year, or for just maintenance and callus debridement that may cause open wounds. So they have the callus debrided. I see wounds, I see gout, rheumatoid arthritis, flat feet, high arches. And so that's pretty much most of what I see, with, of course, all the other stuff that I've gone through. Some of the new technology that I've brought into my practice. So there's a term that we use in sports medicine called biologics. So biologics is it's the umbrella name for using techniques to provide the body with either its own or harvested cells. So, for example, a biologic would be PRP, which is called platelet-rich plasma. PRP is where your blood is drawn, it's spun down in a centrifuge, and when we do that, it separates into platelets and red blood cells. And the platelets are the precursor to all of the reparative cells that your body makes and uses to repair torn tissue. So in someone who has a tendon tear or a ligament tear, or is even developing a problem with their bone, they fracture their bone and the bone isn't healing. They're having what's called a non-union. Sometimes there is an indication for using a biologic to inject into this location that helps to essentially does two things. It restarts the inflammatory process, which is what your body may need, and it provides growth factors and the platelets that it's not getting anymore. And so PRP is one that comes from you. It's your own blood. And then the other is there's many amniotic injectables. So amniotic biologics come from typically the placenta and the umbilical cord, and they are filled with the appropriate cells to repair tissue such as tendon tears and ligaments. And so I'm doing this in my field. I'm injecting it for Achilles tendinosis. So if you feel your Achilles tendon and there's a bulge in the back of your Achilles tendon that's thick and inflamed, I have found that these biologics work well there. And also in other perineal tendons, other problems that you might have, it's an adjunctive to the other non-operative immobilization, anti-inflammatories, bracing, things like that just help to repair the torn tissue. And then, as I had mentioned previously, I'm doing minimally invasive bunion surgery. If it's something that is if your bunion is bothering you, I have found that this is a technique that is getting people back to walking quicker. The recovery is much easier. Their range of motion of the big toe joint is preserved. So one of the problems that you have with bunion surgery is that the big toe joint can become stiff, and this procedure, there is much less stiffness in the big toe joint afterwards. It's a faster recovery. It looks a lot better cosmetically. The incisions are tiny. They're little poke hole incisions. It's done outpatient, and I've been very happy with that operation. So where to find me? There's two websites you can get me on. You can see at the top, it's the orthocentermd.com. That's my practice. And then I have my own website, davidngorn.com. 3 office locations. I go to all 3: Rockville, DC, Germantown. You can get those from the website. I do operate and see patients at 3 hospitals. I go to Shady Grove, Suburban, and Sibley. That is it. This is my my little family.
Thank you so much, Dr. Engborn. That was great, very informative. We do have some questions. So this presentation is recorded. Would you be able to share the slides with the participants after?
Sure.
Okay,
Yep.
Great. I'll get that from you and then I'll share them with all the participants. What could be the cause of occasional non-localized acute pain?
Well, there could be a lot of different things. I mean, I'd have to examine the foot and see, but it's a good question. You know, I'll see you know, people who have some sort of deformity, usually I'll see this type of presentation with. So, you know, they will have a flat foot and they will have this lateral foot pain, right? So it's on the top and the side of their foot, around the base of the fourth and the fifth metatarsals, kind of non-specific. And it's usually from some sort of deformity. And that's where, you know, I have to use my physical exam and also some potentially x-rays, make sure there's nothing fractured, there's no arthritis that could be causing it. You know, and that brings up another point. Arthritis in the foot can cause global foot pain that might not necessarily be related to any trauma. So there could be some midfoot arthritis, which I see often. You know, people come in and they say, you know, they can't really find the specific location. It's all over the top and the side of the back of the foot. And then I take x-rays and there's this profound arthritis in their midfoot. You know, those are some things.
Thank you. So now that you shared the locations, do you know if your practice accepts GIHA, which is part of United Healthcare Choice Plus network?
We do.
Okay, great. Thank you. Next question, if not infected for years, can an ingrown toenail be left alone forever if one is already in mid-70s, as long as it doesn't get infected?
100%.
Okay.
You know, it's a really good question. I have this conversation often with patients, and I probably have it more with kids and their parents, because mom and dad are concerned about the ingrown toenail. And what I conclude is that if it's not painful and it's not infected, leave it alone. You do not need to remove a asymptomatic ingrown toenail, because it may never become a problem. And so, you know, the other part of that is that the normal anatomy of a toenail is that it's curved. Some may look at that and say that's ingrown, but it's actually the normal anatomy. So when you're making a diagnosis of an ingrown toenail, to me, the number one thing that I need to see on the physical exam is pain. So if there's no pain, to me, it's even hard to call it an ingrown toenail.
Great, thank you. Would you recommend exercises to try to keep hammer toes from progressing if it is not too bad?
Sure. So that's a really good question. You know, I think the key with hammer toes is it all depends on what your foot type is. You know, the most important part of preventing hammer toes from becoming worse, I think, is a good shoe. You know, if you are wearing, you know, heels all the time or unsupportive flats, you're probably going to develop the deformity much quicker, or it may progress much faster. I'm a big proponent of stretching the calf muscle. I don't know if that necessarily has you know a meaningful impact on the toe tendons, but I do think that there is the anatomy of the gastrocnemius and Achilles. To me, makes sense that it helps to allow the heel to strike without so much tension, and then therefore the flexor tendons don't work as hard. And so There's runner stretches and wall stretches. So certainly, I think stretching is a very, it can be quite a difficult, routine to get in, but it's really important and may help prevent other deformities from worsening. But ultimately, you know, um, you know, you know, this wasn't the question specifically, but once you have that deformity, and there's no fixing it unless you do some sort of correction. But I do think calf stretches are great for any foot pathology.
Great advice. Thank you. Is toe fungus hereditary? And what other things cause toe fungus besides catching it from people who already have it?
Sure. So, that's another really good question. And it is, there's a genetic component to your ability to be able to fight the fungus. So, it's all about your immune system being able to fight that fungal infection. And we think that it is shared, and so you get it from pools and walking barefoot, and if your spouse has it, showers, things like that, and shared showers. And I always tell people, I get this question all the time, my husband has it or my wife has it, what do I do? And it's the best advice I can give is try and bleach your shower as once a week if you can, and don't walk barefoot around your house.
Thank you. I'll take a question from the chat. I want to make sure we get to all of your questions. So the question is, I have soft custom orthotic that's over 5 years old. How often should custom orthotics be replaced? And in addition, are soft custom orthotics better than hard custom orthotics?
Yeah, so it really depends. If you're not having symptoms, then your orthotics are probably okay. I have patients that come back once a year for them, and the insurance companies pay for that. So there has been enough literature to support that there is a need for a new orthotic once a year. With that said, I see lots of people that come into my practice and they come in 5 years, 10 years sometimes and say, hey, these are the orthotics I wear, I'm not having any problems. And I think in that case, it's fine to not replace it as long as you're not having any foot pain. It really depends on what the problem is that you're trying to correct with the orthotic in terms of soft versus hard. As an example, in people who have really flat feet, they or have very bony prominences, they don't do well with a hard orthotic. They don't do well with a high arch support. So they need something a little bit more accommodative. And so it's uncomfortable. And that's the main thing, is it's not therapeutic because it's rubbing on the collapsed arch. So, it really depends on, what type of foot you have. I think in people who have more bony feet, where there's, if your navicular or your big toe joint is hitting really hard on the ground, more of a softer accommodative device is better. Diabetics who are predisposed to ulceration, they would do better with a softer orthotic. There are companies out there that make diabetic inserts, and those inserts are made from Plastizote that are very soft. And I find that it's great for diabetics, but it's also great for people that have thin skin and bony areas. So it really depends on your foot type.
Great, thank you. So what is the procedure for addressing the bony prominence underlying callus if shaving is not effective?
Sure. So there are, so it depends on where it is. Depends on where it is. That's where I'll start. If it's in the forefoot under the metatarsal heads, there are a few different things that can be done. And so one of those is, there's a couple. One is you could shave some of the bone down under the metatarsal heads. Just shave it down. Take a little sliver of bone and get rid of it. The other is there's an osteotomy or a bone cut that you can make, that you cut the bone and you let the metatarsal float. It basically floats up. And so there's a little bit less prominence there. If we're talking about a callus that's in the midfoot or around the navicular because of a flat foot, or if you're talking about a callus that's under the base of the fifth metatarsal from a high arched foot, these are a little bit more, these are due to more deformity, and there may be, there's osteotomies that we make, there's tendon transfers that I do, realigning the foot and fusing it in that position. There's a handful of different operations based on kind of where the, where the callus is. I'm the type of, I practice where, less is more, right? So if I can get away with making a small incision and shaving the bone down, then I will. And I think that sometimes that's all you need. It's just a little shave, and that's and move on. You don't need bone cuts and screws and all these, fusions. But certainly I'd have to fully evaluate what the problem is that's causing the callus to form.
Got it. Thank you. Are there any set of foot and toe exercises that are smart for seniors to do each day that will help offset the development or the pain associated with feet as one ages? Bunions are the challenge for this individual, but in general, are there any proactive steps that they can take?
Sure. So I love, the runner stretch where you're up against the wall and one knee is bent, the other one is back and straight, or you kind of, see if I can show this with my hand, you're kind of dorsiflexing your foot, so you basically cross your leg over your left leg over your right leg, and you grab your foot with the left foot with the left hand and just dorsiflex, just pull up and hold and hold and hold, and you hold that for 30 seconds and then relax, and then hold for 30 seconds and relax. And you're just really stretching out the plantar fascia, you're stretching out the intrinsic muscles in the foot. In regards to bunions, there's really not many stretches you can do, but certainly when you're wearing a shoe, you can put a toe spacer in that just realigns the joint, and that may make you feel better if the joint is not asymmetric, and so, but really not many stretches. Does moving your big toe up and down, or curling and grabbing marbles help? It might. So those are some other things.
Great, thank you. Since we only have 1 minute left, I want to try and, we didn't get to everyone's question, so I want to kind of ask a question that many people had. First, how can you find shoes that are best for your feet? In particular, if your feet are irritated on both sides, and after you have bunion surgery, can you wear any shoes you'd like?
Yeah. So I am, so after bunion surgery, you can wear any shoes. I mean, especially doing minimally invasive, pre this technique, with big toe joint stiffness, it was a little bit harder to get into a higher heel, but even with stiffness, or even if you do a big toe joint fusion, so the two bones are glued together, you can still wear, I tell patients that the expectation is maybe a 1-inch wedge if that's what you want, what you want to get into. But I think, if you're looking for a sneaker, my recommendation, Hoka's are great. I get a lot of good feedback about Hoka's. If you're looking for more of a dressier shoe, Vionic has really made a name for themselves in that industry. Some of these shoe stores around town are really good, and their salespeople are great. They sell good supportive brands. Comfort One is one that I really like, and I've had a relationship with. They have a bunch of different locations around. I've met them before, I've worked with these guys before, but if you're looking specifically for a brand of I like Vionic, I like Hoka. I'm a big Brooks running shoe guy. I like Brooks. I think they're super comfortable, good, they have a good support. They're nice and supportive. And what I like about Brooks is that with Hoka, Hoka has designed their shoe in a way that is an arch support. I mean, that's pretty much what it is built in. With Brooks, they have designed a shoe. They have designed shoes that have arch supports in them, and they have designed shoes that are neutral. So you can use a custom orthotic if you need to and put it in the neutral shoe to get the arch support you might need from the device, but not from the shoe.
Great. Well, thank you so much, Dr. Angorn. It was very informative. I can speak for everyone when I say we learned a lot. I'm sorry we didn't get to everyone's questions. However, I will be sharing these slides that has how to reach Dr. Angorn in the future. So thank you so much to everyone for joining, and thank you to Dr. Angorn.
Thanks, guys. Have a good day.
Have a good day, everyone.